Okay, today I'm going to talk to you about MRSA guidelines. I'm going to try and do it in 20 minutes. I'm sort of notorious for talking too much, so we'll see how we go. Some of you, I suspect, are probably too young to remember the early 20s, how do you call that? 2000s, I suppose, when MRSA, as a cause of serious invasive infection, was a major problem in the UK, and indeed in other places in Europe, but many countries in Europe were considerably better than us. We had roughly about 40% of all Staph aureus bacteremias in the early 2000s were resistant to methicillin, and it was a major problem. One of the really important lessons of the whole programme to reduce MRSA as a problem in the UK was that infection control works. So this slide just shows you the change that happened in the rate of MRSA over that around about 5 to 10 year period. It was multifactorial. It wasn't just one thing that resulted in change, but a key factor was recognizing that MRSA was a significant problem, caused significant mortality and morbidity to patients, and that we needed to apply best practice in infection control if we were going to prevent these infections, and that prevention was completely possible by applying those principles. We're in a much better position now. That chart at the bottom really illustrates the huge decline in MRSA as a cause of invasive infection, but you can see it still exists as a problem. We haven't really changed the incidence of MRSA, and in fact, interestingly, in the last 2 years during the pandemic, we've actually begun to see an increase, especially in intensive care patients, and that really indicates that where we don't apply best practice in infection control, these infections re-emerge as a problem. And I'm sure many of you can reflect on what happened, particularly early in the pandemic, when the use of PPE and the approach to hand hygiene was pretty poor, and that resulted in the transmission of other pathogens between patients. So the MRSA guidelines, the last version were published in 2006, and the Hospital Infection Society and the Healthcare Infection Society, Infection Prevention Society have been working over about the last 4 years to update those guidelines. And these were published in the Journal of Hospital Infection last year. Now, often guidance that you get out of government organisations calls itself evidence-based, but it's not really based on a robust methodology in evaluating evidence. I'm sure you're all aware that you can get evidence from anywhere, but actually critical appraisal of that evidence is essential so that you can balance how good the study is and how reliable the conclusions drawn from that study really are. And so the methodology underpinning these guidelines are the most robust methodology that you can use. They're the methodology endorsed by NICE, defined topic areas with defined questions, and only including recommendations or qualifying recommendations according to the evidence that is available to support them. I'm just going to touch on some really key things that are critical to preventing MRSA becoming a problem. So I haven't covered everything in the guidelines. It's freely available from the JHI website, so do go and look at it yourself. I think you'll find it quite easy to read, and it provides you with that sort of underpinning evidence that you need to inform practice. So decolonisation is absolutely critical to the control of MRSA, and that certainly was one of the key factors that supported those reductions we saw in the early 2000s. So these sound fairly obvious, but actually if you think about the information that you give to patients, how clear are you about what patients need to be told when they're asked to decolonise? So making sure the skin is wet before you apply the chlorhexidine, leaving it on for 1 to 3 minutes before washing it off. If you're using chlorhexidine wipes, there's good evidence for the efficacy of chlorhexidine wipes, but you mustn't wash it off. You leave the chlorhexidine in contact with the skin. You need to be aware of potential problems with sensitivity reactions. Pay special attention to those areas of the body which are highly likely to be colonized with MRSA. That's where it likes to live. Avoiding neonates. It's not safe to use in neonates. And the key factor here is that it may not eradicate the MRSA. So what it tends to achieve, the evidence shows us, is temporary suppression. So you always need to be aware, and patients need to be aware, that it will eradicate it, but it may come back, particularly if they go back onto antimicrobial agents. A second key area that people worry about a lot is the environment and equipment. So what the guideline tells us is that we shouldn't sample the environment routinely. That's only important where you've got evidence of transmission and you may have a single point source. I'm going to talk a bit more about HPV as an adjunct to terminal cleaning of rooms for patients who've had MRSA. And there's a key message about staff being aware of their specific responsibilities for cleaning. So it doesn't become nobody's job, because there are clear, defined responsibilities. Shared equipment is a huge problem, and again, we saw this in the pandemic with the transmission of all sorts of multi-drug resistant pathogens between patients, because the tendency for staff to wear gloves and then touch shared equipment with gloves on, not recognizing that those gloves will transmit pathogens around in the same way as hands. And it's totally impractical to clean things like computers, computer on wheels, or devices that use observation trolleys between patients. You need to decontaminate the bit that touches the patient, but if you have staff working between patients and the device and not decontaminating their hands, they will contaminate that shared equipment. So the key thing about shared equipment, and you can see the chart here comes from one of the papers cited in the study. It shows you all the sorts of studies that show these things just pick up pathogens. You would expect them to. But the key thing is that staff must wash their hands after touching shared equipment and before touching the patient. A lot of people really love disinfection. But again, there's a lot of practical problems with using something like hydrogen peroxide. So what the evidence tells us is that it does work for some pathogens. Fogging a room with HPV, in this particular study, reduced acquisition of multi-drug resistant organisms. But interestingly, the reductions they saw were really driven by vancomycin-resistant enterococci rather than MRSA. And that's perhaps not surprising. VRE has a much stronger association with the environment. It contaminates the environment to a much greater extent, and it's much more pervasive in the environment. So HPV may not be terribly relevant for MRSA, and this particular study was also, this is why quality assessment is so important, high risk of bias and confounding. There are other studies. This is a good study by a team in Australia, looking specifically at the role of HPV for MRSA rather than more general multi-drug resistant organisms. But you can see that, and this is an interrupted time series, which is a good design, so you're checking acquisitions of MRSA before you put an intervention in place, and then you look to see if there's a significant reduction over time, measuring after you've put the interventions in place. So you can see where they put in place hydrogen peroxide, but of course they added in additional patient screening as well, so you're never really sure which of those two interventions were relevant. And the authors themselves discuss how HPV has a lot of practical problems because you can't really use it unless you have a contained area. And obviously, most UK hospitals manage many patients in bays rather than single rooms. And the other thing about disinfectant, which again the guideline focuses on, is that actually it's really the cleaning that's really important. There's no point using HPV if you haven't cleaned the room because it will not disinfect dirty surfaces. And actually this study by Mark Garvey in Birmingham, nice study, it's quite, it again has a lot of potential bias and confounding because it's a very pragmatic study. Again, interrupted time series design. And you can see once they introduced essentially a simpler method of cleaning, just using a detergent wipe, then they saw a reduction in MRSA acquisitions. And that probably tells us a lot more about assuring the quality of cleaning, whether it's with detergent or disinfectant, rather than the actual use of disinfectants itself. Now, we often, as a knee-jerk reaction, just move to isolation as being the solution to prevent transmission, without necessarily thinking about, well, what is the evidence that this intervention works? So what the guideline says is consider isolation and contact precautions for patients with MRSA, but base it on risk assessment. So that's not saying it's appropriate for everybody. And the factors that risk assessment should take into account are the extent to which the patient is colonized with MRSA and the availability of rooms to put them in. Because in terms of risk of transmission, and indeed the evidence for efficacy of these precautions in preventing acquisitions, it's not a high priority to put patients in a single room because it probably makes little difference. And I'm going to show you some evidence to support that. So here's a couple of studies here. The one on the left used universal gown and gloves in an intensive care setting to try and reduce MRSA. And notice VRE acquisition as well. So often these sorts of studies focus on more than one multi-drug resistant organism. And in fact, they didn't, although the intervention decreased room entry, so patients were less likely to be visited by healthcare workers, and it did increase hand hygiene after leaving the room, it had no effect on MRSA acquisition. So using routine gloves and gowns didn't change acquisition. And this study, it's quite a well-known study by Cepeda, looked at ICUs, and actually what they did is they stopped moving patients with MRSA into a single room, and they looked to see if that had a significant effect on acquisition. So did it make a difference putting them in an isolation room? And they found no difference in rates of acquisition by not putting them in a single room. So it's an often used strategy, but actually there isn't evidence that it works. If we look at contact precautions, there's a number of studies that have looked at contact precautions. Occasionally, often if the prevalence of the infection MRSA is very high, then there is some evidence that it has an effect. But this is quite an interesting study by Bierman, again, an interrupted time series. And actually what they did is they took away contact precautions where it's got that intervention. They took away contact precautions, and they found no significant change in acquisition of MRSA by taking away contact precautions. One of the other really interesting things that they found, so you can see there that they discontinued contact precautions, no significant change in rate of acquisition, but actually what they did find, you can see at the table at the bottom, that once they discontinued contact precautions, for those patients were at much lower risk, significantly lower risk of acquiring infection with multi-drug resistant organisms. And I would argue that the problem with contact precautions is that we use it as a knee-jerk reaction to deal with these organisms, but actually what happens is people put gloves on when they enter the room, never take them off, and so those organisms colonizing the patient's skin are just being transferred on those gloves into the susceptible site on the patient that you've got in isolation. So contact precautions, this study suggests, are actually hazardous to the patient who you've put in contact precautions. And of course, this also illustrates misuse of evidence, really. So contact precautions comes from this guideline. In fact, it was sort of invented before this guideline, but this is the only guideline really or it underpins any other guidance. And you'll recognize those transmission-based precautions. But actually, that whole guideline was not based on a thorough evidence review. And actually, they made a lot of strongly recommended guidance where it was really just the opinion of people who were sitting out around the room making the guidelines, and it wasn't based on any definitive scientific studies. And we now have much more evidence that contact precautions and isolation aren't necessarily as effective as these people assumed they would be. And if you want to hear more about that, then there's an editorial in JIP, and this is also a podcast that I did with Martin Kiernan recently. one of the reasons that we need to be really careful about how we use contact precautions and isolation is that the evidence that we reviewed for the guideline shows that we are confusing patients massively. They don't understand why they're being isolated. They're confused about how people use PPE, and that's sort of not surprising if you reflect in your own organizations how PPE is used, how PPE is often used instead of hand hygiene, and hand hygiene doesn't occur. Then patients who are sitting in a room recognize that. They can see that variation in practice. It's very obvious to them. And that leads to feelings of anger and frustration about not really understanding why people are doing this. They're seeing lots of inconsistent practice, and they're being kept in a single room. That's not to say that isolation isn't perceived to have some benefits for them, because it means they do have some privacy, and they talk about it's nice to be able to have visitors in a single room and have that privacy. But they also recognize it's associated with a lot of negatives, and they also take on messages, which again is why it's so important that we help them understand what they're there for. They take it as an indication that they're perhaps seriously ill because they've been put in a side room, or maybe they're not very ill for some people who are put in a side room. So this whole sort of lack of communication and lack of information for patients about MRSA. This is a recent systematic review that is really helpful in terms of bringing together the impact that isolation has on patients. So from 15 studies, lots of evidence for an effect on mental well-being, depression, anxiety, fear, loneliness. Patient satisfaction, I mentioned, it can improve the experience, but if it's going to improve the experience, patients need to be really kept informed about their care. And one of the real big problems of isolation is it increases adverse events. And you can see from this systematic review an 8-fold increase in adverse events on these patients. And that is both because it's not easy to see a patient in a single room, but also the contact time with staff is significantly reduced when people are isolated. So in this retrospective case control study, they looked at pairs of patients, one being isolated with MRSA and a similar patient not being isolated, and they just looked at bedside visits by medical staff. And they did that by looking at the case records to see if the doctors had written anything in the case sheets about this patient. So really significant effect on reduction of bedside visits when a patient was isolated with MRSA. What do patients say about isolation? I don't want to tell other, or about MRSA and isolation, either or. I don't want to tell other people that we have it. I used to be very social, so they have a sense that they're contaminated, infected, and that they shouldn't mix with other people. It was difficult. I was isolated and locked in a room, and I didn't get out. You don't feel like a human being. I mean, there's got to be a different way of treating people with MRSA. Nurses themselves found it uncomfortable, and they got dressed in battle gear from head to toe. It was really chaotic. Nobody ever put energy into telling me anything about this. That's a really telling phrase, isn't it? And therefore, my knowledge of the disease is the same now as it was before. But I think one of the reasons for that is this quote. I've come to the conclusion the reasons nurses didn't tell me very much is because nobody knows very much about it. So the message from that is that we need to make sure people, that our staff are aware, and that perhaps IPC has a much greater role in making sure that patients are fully informed. Those are the recommendations for practice. So giving patients reading for screening and about isolation, consistent information, both while they're in hospital but also on discharge, about all the different elements of MRSA that they need to know about. And as part of the guideline, we've developed 2 patient leaflets with the Patient Association and MRSA Action. And I think you'll find these really useful as a resource to try and ensure that you get more consistent information out to patients. And if you go to the Health Care Infection Society website, you'll see some other webinars and other information about the guidance that you might find useful.